Thank you for joining this session, the next session in our oxygen series, Care of Pediatric and Adult Patients, Pulse Oximetry and Oxygen Therapy in a Time of COVID-19. We have a fantastic group of panelists here today. Leading them off is Dr. Thomas Weiser, Consulting Medical Officer, Lifebox General and Trauma Surgery, Stanford University Medical Center, Dr. Mayoum Barka, DRC Country Representative, ALIMA COVID-19 Response, Dr. Susan Shepard, Pediatrician with 10+ years experience in childhood malnutrition, Dr. Hitendra Mahajan, Anesthesiology and Intensive Medicine, Ashoka Medicover Hospital in India, and Dr. Ashraful Islam, Senior Medical Officer, Projahnmo Research Foundation, Bangladesh. Next slide. Before we get started, I'm just briefly going to run through the Project ECHO etiquette rules, or guidelines, I should say, and then pass it along to our panelists. So Project ECHO is based on a foundation of love and respect. Please respond kindly rather than react if you disagree. It is everyone's responsibility to keep ECHO a safe space. Please test your equipment ahead of time. Position your webcam effectively to show your face if you are alone or to capture an entire group. For questions and answers, we will be using the chat function. So you'll see a chat box at the bottom of your screen. Please send all questions through the chat box and feel free to introduce yourself. We do have interpretation in 2 languages. So please, you'll see an interpretation button at the bottom of your screen. For Khmer, please choose the Chinese interpretation button. And for Vietnamese, please choose the Spanish interpretation button. We apologize, Zoom does not allow yet for a Khmer or Vietnamese link. If you have any IT issues, please send a message directly through the chat or email at echo@assistinternational.com, and we will try to troubleshoot with you. And we just want to know, please be mindful of infection prevention and control. Try to limit the number of people joining this learning session from one gathering place, and please practice physical distancing. With that, I'm going to pass it along to Dr. Thomas Weiser.
Thank you so much to everyone who's come to participate today. Welcome to this virtual grand rounds on pulse oximetry and oxygen therapy in the time of COVID-19. Thank you to Assist International for hosting this session, and to our co-sponsors, the Alliance for International Medical Action, Stanford University, and Lifebox, and to our panel members and to all of you who are joining us today. The format of the session will be to have a 30-minute panel discussion, followed by 30 to 45 minutes of question and answer sessions. If you have a question, please write them in the chat button, which can be found at the bottom icon of your screen. We will stop promptly at 1 hour and 15 minutes, but we will do our best to respond to all questions posted to the chat. Please allow me to introduce our panelists. Dr. Baweye Mayoum Barka is ALIMA's country representative for COVID-19 response in DRC. He's worked for ALIMA for 8 years in various contexts of malnutrition, population displacement, various outbreaks of measles, cholera, hemorrhagic fever, and previously to COVID, Dr. Baweye managed the medical intervention of Ebola with ALIMA in DRC. And prior to that, he was their medical team lead in Niger, Mali, and Guinea. Dr. Ashraful Islam is a physician and medical researcher and is currently the senior medical officer in Projahnmo Research Foundation in Bangladesh. His areas of interest are respiratory disease, in particular pneumonia, asthma, tuberculosis, and bronchiolitis of children under 5. Dr. Islam has worked on numerous studies in collaboration with Johns Hopkins University, the University of Edinburgh, and the Child Health Research Foundation. Dr. Hitendra Mahajan is a consultant anesthesiologist and intensivist at Ashoka Medicover Hospital in Maharashtra, India, with a special interest in neurotrauma and regional anesthesia. Dr. Mahajan has been working on the front lines of COVID-19 pandemic in the COVID ICU as well as giving anesthesia to suspected COVID patients. Dr. Susan Shepard is a pediatrician with over 10 years of experience in child malnutrition and has worked with ALIMA since 2013 on developing the new strategies for managing childhood malnutrition. Dr. Shepard was instrumental in development of the COVID-19 decision support tool, which we'll discuss today. As we all know, measuring oxygen saturation of a COVID patient has become fundamental to understanding how severe a case of COVID is. Being able to identify the severity is vital to appropriate triage, whether it's isolation at home, admitted to a hospital, or a high dependency unit, and then how much oxygen support a patient might need. Lifebox and ALIMA has worked to develop a COVID-19 decision support tool to help guide clinicians during the COVID-19 pandemic. It uses oxygen saturation measurements from a pulse oximeter to determine when oxygen support is indicated. The tool was created as guidance for frontline providers in low resource settings working with patients with respiratory compromise and suspected or confirmed COVID-19. We will be presenting on this tool today, which is available on the Lifebox website. We would also like to highlight the WHO's Clinical Care Toolkit for COVID-19, as well, also linked on the Lifebox website. We hope that today is an opportunity to share lessons learned in terms of oximetry and oxygen therapy from both Africa and Southeast Asia as we grapple with this new virus and continue to try to provide the best possible care for COVID-19 positive patients. Thank you all so much for sharing your knowledge and experience with us today. And let me start the discussion. I'm going to start this discussion with a question for all the panelists in order. I would like to ask each of you to say a few words in turn on the current situation of the pandemic, where you are based, and follow up with how your respective organizations have responded to COVID-19. And I'm going to start with Dr. Susan to tell us a little bit about the ALIMA response.
Hello, everybody across all time zones. So thank you, Tom, for the kind introduction. ALIMA began responding to COVID back in February of this year. First, a few words of background on who ALIMA is. It's a medical humanitarian organization that is primarily involved in emergency response, particular expertise in maternal and child health care and epidemic disease such as Lassa fever, Ebola, cholera, and now COVID. ALIMA has around 40 projects in 12 countries in West and Central Africa. And since early March, we have responded on two tracks. First of all, for all of our standard projects, we have been boosting triage and infection prevention control training for our staff, ordering in more PPE. And then the second track is we've opened COVID treatment projects in 6 countries. Senegal, Guinea, Burkina Faso, DRC, and Cameroon, and Nigeria. And in these 6 countries, we have 9 projects. And we have, over the past 3 months, treated just over 3,000 COVID positive patients, of whom 10% were severe oxygen requiring, and whom 2,400 have happily recovered. We manage a total of about 925 beds. We have projects that are on 2 different scales. We have projects that are run in tertiary care academic hospitals in Conakry, in Ouagadougou, and as Dr. Baweye will talk more about in Kinshasa. And we have projects that are in district hospitals in Dakar, for example. So, as I'll talk about a little bit later, one of the main goals of our response is, giving people the tools to detect severe cases early so that we could get them to proper levels of care. With that, I think I'll hold off. I'll pass to the others. Thanks, Tom.
Thank you, Dr. Susan. Let me turn to Dr. Baweye for ALIMA's approach in DRC.
Yeah, good morning, Toms, and good morning also to all the teams around you, and also my greeting to panelists and others organizations who support these discussions, and also to people who are joining for these webinars. So as ALIMA country representative in the DRC, so just to give you how about the current situation now in the DRC regarding pandemic of COVID-19. In the DRC, we are already to 100 days of the COVID notification in the countries. We close now to 6,000 of the confirmed case of the COVID in the DRC. And with around, from the last 14 days, we have average weekly 1,200 notification weekly. But most of those notifications, where the alerts are coming from the active case finding and also from the community. But most of, among those 6,000 of the notifications, confirmed cases of COVID-19 in the DRC, 90% of those cases are concentrated in the DRC. But what I want to precise here in this discussion regarding to the COVID-19 context in the DRC is that the capacity of the testing, which is limited. So from the sense start notifications in the Kinshasa, we test around 20,000 of the suspicious patients. Among of them, only 5,000 are confirmed. So if we look at the average range of the capacity of the testing for the COVID in the country is almost around 250 tests a day, which is a very, very low, only at the Kinshasa level that we have around 12 million of the population. So it's something difficult. And what I want to precise also in the DRC national response plan is that all the asymptomatic cases should be managed at home, and only those who are confirmed should be managed at the hospital levels. So but for the ALIMA, in the DRC, we are responsible in the two parts of the DRC. Kinshasa, which is located at the west part, and also the North Kivu, where last year ALIMA response in the Ebola disease. Also, we are organizing also a response in the east part, which is close to the border of the Rwanda and Uganda. So our approach as the ALIMA is that to support the Ministry of Health in case management. So in the Kinshasa, we are supporting the Kinshasa University Teaching Hospitals in the COVID case management that I will talk more in the details we are coming. Thank you, Thomas.
Thank you, Dr. Baweye. Dr. Hitendra, may I ask you about the situation in Maharashtra in India? And remember, you're on mute, Dr. Hitendra, if you can unmute.
Yeah, okay. Can you hear me now? Yes, I bring greetings from India, Maharashtra, Nashik, my town, to all of you. In India, as such, we are having around almost 0.3 million cases. The doubling rate has definitely gone up, but then now when we are opened up with the lockdown, though we are seeing an increase in the number of cases, the symptomatic cases are not rising that alarmingly. As far as my town, Nashik, is concerned, the population of my town, Nashik district, is almost 67 lakhs, that is 67,100, and we have somewhere 2,000 positive cases, COVID positive cases so far. And our testing rate, yes. Hello.
Go ahead, Dr. Hitendra.
Hello. Hello, can you hear me?
Yes, we can hear you. Go ahead.
Yeah.
Yes, we can hear you.
So in my town, we are definitely there is a rise in the number of cases what we are facing. We are almost doing some 1,000 testings per day, out of which almost 5 to 10% are only coming positive. Rest of them are coming negative. And there is a contact tracing. As far as my hospital is concerned, we had kept it is a private hospital, so we had kept the dedicated ICU of 16 bed and 16 beds, non-ICU beds, where we can give oxygenation and monitor them. So they are almost full, and that way serious symptomatic patients we are receiving less as compared to less symptomatic and asymptomatic cases. That is a situation at present in my town here in Nashik, Maharashtra.
Thank you, Dr. Hitendra. And then I'm going to turn to Dr. Ashraf, and would you tell us a little bit about your situation in Bangladesh, please?
Yes, thanks, Tom. Can you hear me? Yeah. Am I audible? I don't know. Like, yeah.
We
Okay,
can hear you,
fine.
yes.
Yeah. Thank you so much, and good afternoon, and a warm welcome from Projahnmo Research Foundation. I'm Dr. Ashraf. So as we all know that the coronavirus disease, the outbreak started from Wuhan, China last year, December. But in Bangladesh, the first case started on 8th of March this year. And since then, the number of cases are actually, they're increasing. As of today, the whole country has been, we have reported 119,198 positive cases and 1,545 deaths. So I live in northeast of Bangladesh. It's the city is called Sylhet, and I live in a sub-district of Sylhet, which is called Zakiganj. So it's a small town of around 400,000 people. So till date, we have screened more than 700 symptomatic cases, and we got around 90 positive COVID patients. So the Zakiganj hospital is a 50-bedded hospital, and it has an isolation beds of around 15 of them, but it doesn't have an ICU support. If the patients are in moderate or severe cases, then we are actually referring them into a tertiary hospital in the Sylhet city. So I just want to brief a little bit about the distribution. Like, I think in globally, this is same as what we are also seeing in observing in Bangladesh, that most of the people, the age group that are infected is like 21 to 30 years, around 28%, and 31 to 40 years, around 27%. And also the number of male cases are high, like 71 versus 29. Even the deaths by gender is high, like for the male it is high, 77 versus the 23 in females. So Projahnmo Research Foundation is a research-based organization, and we have been conducting research with maternal and child health for the last 20 years in Sylhet and Dhaka. So in collaboration with Ministry of Health and Family Welfare and other national and international organizations and universities, just to name a few, Johns Hopkins University and University of Edinburgh. So due to the current situation and as per the research protocols and the government guideline, so we have paused our temporarily all activities in field. The field activities, just we are thinking that it may pose some risk to our study staff as well as to the participants. So we are basically working from home and following the national guideline. And recently government has started, they've divided the regions into 3 zones. Okay, as like for example, a green zone, a yellow zone, and a red zone. So basically, this is depending upon the number of cases per 100,000 population. For example, for red in an urban area, for example, in a city, if the number of positive cases in the last 14 days is 60 or more, then the government is declaring that as a red zone. So this is the most alarming zone, and there are many restrictions in that zone. People restricted getting out or in of the from that region. And in addition, only emergency supplies are being provided there with medicals and emergency food or any kind of urgency. But people usual walking and usual going out is being restricted in those regions. So this is from my side, and okay, so thank you. Back to you, Tom.
Thank you, Dr. Ashraf. So very, very interesting. Lots of new changes to the medical system. Lots of a pivot towards managing the concern for high numbers of cases. I'd like to ask you a little bit. So this is you've now given us a little bit about your perspective on the field. I'd like to ask you a little bit about what you have you've learned. What has been the major lessons and experiences that you'd like to share from your respective regions? And I'll start with Dr. Baweye. You've talked to us a little bit about the organization of medical care. Tell us what lessons you've learned over the past several months while treating patients.
Okay, thank you very much, Tom. Is very nice because from the last discussions, I think we have moved. And the opportunity that we have as the ALIMA, comparing in regard to other treatment centers, is that our approach, our integration into the teaching hospital. Because in the teaching hospital, we have this opportunity even to apply the other international conclusions related to the COVID-19 case management. For example, the administration of the dexamethasone for us is, I can say, is the only unit in the Kinshasa, even in the DRC, that we decide to give dexamethasone to all the patients admitted in the unit with the severe respiratory distress and needing the oxygen supply. So this is the one thing which is very important. The second thing is that also this ability to change in the triaging triaging unit, or even putting into place the circuits. Because the nationals, DRC nationals recommendation, they have a sheet already that should be applied in all areas. But in the teaching hospitals, we know why it's very important to check the oxygen saturation at the triage. So this, we succeed in modifications and also putting into place with the pulse oximeter directly from the triage. Even the person is symptomatic or even asymptomatic, from the assessment from the beginning, we have to take the saturations at the beginning and to orient the patient according to other definitions, criteria. But our major criteria also is depend on the saturation from the admission. So we can decide knowing if this patient needs to be admitted according to the different unit that we divide. The oxygen saturation, that the oxygen monitoring that we need, maybe close monitorings, or if this needs, because even in the monitorings, we have maybe 3 times, 4 times in the daily monitorings, and reduce according to the saturation that we are taking at the triaging. And also because we have other patients in which they need other invasive treatment, for example, the hemodialysis. So this is the only unit, this is the only place at the teaching hospital that applied the international recommendation that I can say in comparing to others, places that they still behind and also stick to the national recommendations. So this is the experience that I can share. So later on from the presentation, I will explain more in details my experience that I spent the last week, complete the week inside with the medical doctor in the unit, even seeing the patient, COVID-19 patient, treating and moving around. So I will explain more in details in the presentation.
Thank you, Dr. Baweye. Yeah, really interesting, especially around dexamethasone and you know, the new steroid treatments that that have just recently been released. Dr. Susan, would you tell us a little bit about some of the lessons learned and some of the experiences you've had updated since our last discussion?
Yeah, sure. Thank you, Dr. Tom. Just to build a bit on what Dr. Baweye was saying, Tom, if we go back to when we started working on this decision tool back in, I guess it was in late March or early April, we were focused primarily on pneumonia and diagnosing hypoxemia. And since then, I think we've come to understand a few more things. So in addition to the importance of the hyperinflammatory response that dexamethasone seems to improve, we've also have learned that SARS-CoV-2 infection primarily is, it attacks the endothelium and it causes thrombotic disease. And so we've also instituted anticoagulation therapy as standard prophylactic treatment for all patients who are classified as severe or critical. The other thing that we've learned is that helping patients to change position can oftentimes improve oxygenation. And as you can imagine, in the countries where we are working, and probably even in general, if you can avoid intubating a patient, it's certainly the preferable option, right? And so using strategies, so asking respiratory therapists to assist patients in changing, lateral, decubitus, right or left, or even proning can help oxygenation. And we're also finding some success using CPAP. And so for example, in our project in Conakry, the most severe patients are on CPAP, and I don't think that they have intubated anybody yet, and mortality rates really remain relatively low. The other thing that we've learned seems, fortunately, mortality rates in sub-Saharan Africa seem to be substantially lower, for reasons that we don't fully understand yet, but so far that's our observation. So I would say those three things: anticoagulation, changing position, CPAP to support those who require more ventilatory support beyond supplemental oxygen.
Thank you. Very, very, very interesting, Dr. Susan. Dr. Ashraf, can I ask you to tell us a little bit about some of the lessons you've learned and the experiences recently in your situation?
Yes, thank you, Tom. Yeah, I want to add with that, I have a little bit of experience about the dexamethasone actually. So what's happening in most of the regions, like because this is an epidemic and everybody is also in a fear in the general population. So what's happening is, like, for example, the media is showing that, so dexamethasone is working good for the COVID patients. So the general population, what they're trying to do is they are purchasing dexamethasone by themselves from the pharmacy, and they're keeping it for the safe side. But we also know that dexamethasone is also a steroid. So maybe personally, what I feel is that giving this dexamethasone as a in the first 5 or 6 days before when a person is infected with COVID, maybe this will reduce their immune system. So maybe instead of doing good, it will turn worse for those patients. I believe dexamethasone will, of course, definitely it will help if the patient, the severity of the disease is very high. For example, if there is cytokine release or cytokine storm syndrome is happening, or if the patient is very critical. So for those, yeah, of course, definitely it will reduce the death rates, of course. So this is one experience. And yeah, another experience what I felt is, I will talk about it later also, it's about the silent hypoxia, because I'm seeing like there are patients who are walking, talking, but their saturation level is low. Okay, but it's very difficult to understand because they're not symptomatic, or they're not showing respiratory distress. So for these, like, this is an experience which I've learned that, yeah, we should have a pulse oximeter and we should monitor them regularly. Thank you.
Thank you, Dr. Ashraf. Very, very interesting and very important kind of potentially perverse effects of dexamethasone and its kind of general use in the population, as opposed to its very titrated specific use for severe COVID patients. Dr. Hitendra, will you tell us a little bit about the situation currently in your context in India, and a little bit about some of the recent experiences you'd like to share? And you're still on mute, so I'll ask you to unmute your button there.
Mute, yeah.
There you go. Thank you.
Yes, lesson learned. We learned a lot of lessons. Though it has come quite earlier, right from the December in Wuhan, and we were reading all the things about a lot of things about COVID. But when first case we faced, that time we realized that yes, reading and preparing ourselves is a different thing, and facing itself is a different thing. I'll I'll subdivide this lesson learned into three categories which are very important in this situation. First thing is government level. What policies government decides? Because in at least in a country like India, being a private practitioner, still we have to, as the country comes under the Pandemic Act, we have to follow all the recommendation. And we had seen so much interference from bureaucrats who are supposed to be in a preventive stage, who are supposed to work on a preventive at the society level, but they started interfering in treatment part. So that lesson we learned, that even government learn and bureaucrat learn, and all of them, it took us first 2 to 3 weeks to realize that how we should go ahead handling this situation. As far as healthcare worker is concerned, when we faced our first case, though we were knowing everything, still we came across our first case as an accidental case. The case came to the hospital for a bypass, for a cardiac bypass surgery. And then by that time, we had decided that we will, every patient, or wherever there is a time, like where we have a 24 hours to 36 hours before taking them for a surgery or like that. So we found out that first case turned out to be a positive, but we took us 24 to 36 hours to realize exactly. Though theoretically we were saying that yes, we should protect ourselves, we have to protect other patients, we have to create a different areas in the hospital, but when it comes to the real application, it takes a lot of there is definitely a learning curve. That time when we faced our first patient, we realized that it is not only about preparation from a hospital point of view or policy point of view, but it is also from a psychological point of view of entire healthcare workers, not only doctors but nurses and everyone. So that created a sort of storm, and then we need to create another environment, we need to communicate with everyone, and then we need to bring everyone on a one platform with a frequent communication from leaders to consultant to sister level, so as to exactly make them aware of the situation and decide a policy how to face it. Because we had seen a lot of psychological disturbance also, because there were a lot of myths about, in spite of being from medical background, there are a lot of myths about corona and COVID in everyone's mind. And from patient's point of view, yes, in last 2 months, as we are dealing with variety of patients, initially we had seen, as I said, our first case was accidental case, there was no respiratory symptoms, but then we started seeing a lot of respiratory. In our hospital, what we did is, after learning all these things, we created a triage area where everyone, whoever comes in the hospital, obviously we restricted the relatives outside, only patient or at the most one relative will come, that too in a triage area where with a safe distance, a person with a full protection will examine. Suspected that he will be sent to as earlier mentioned, we found a silent hypoxia in most of the patients. Whenever in our triage area, three things we concentrate: one is temperature, second thing is pulse oximeter, which was very, very important. We found out most of the patients, they will be very comfortable walking, but when you check their saturation, they'll show 88, 89, 91, like that. So that was our first filter. And then obviously third step used to be a CXR or a HRCT screening. Just to reduce the cost, we started screening them rather than taking the prints and all these things. But this thing helped us a lot in isolating those patients. And then we divided entire hospital in red zone, gray zone and green zone. So any patient who comes to hospital has to go to gray zone, and from there, once the COVID report goes and confirms, then he goes either to the red zone or he goes to the gray zone. That's how we divided, and we learned a lot of things. Yes, we had seen a different presentation. In spite of all this preparation, apart from respiratory problems, what we had seen most of the presentation is loose motion. Very common. Patient coming with a loose motion, and then later on, after third day, they'll show respiratory signs. But then as our policy is like HRCT screening, pulse oximeter, and this thing, so we could suspect them because of this 2-3 things, and we could put them in a isolation and then shift to the this thing. Yes, the patient with a comorbid diseases, we had learned that yes, those who are suffering from suppose GIT problems, they started presenting with the GIT problems, pain in abdomen, rise in mild pancreatitis, cholangitis, all these things. And then after second day, we used to realize that yes, they are turning out to be a COVID positive. So somewhere this virus is making all these comorbid disease more symptomatic rather than presenting as a respiratory problems in these patients. And another thing what we realize is false negativity. We were from clinically, we could suspect that yes, these patients are definitely COVID type. They are fitting into all the symptoms, but then their first report came negative. So initially what we used to do is with the first negative report, we used to send them on a green zone. But later on we realized that no, it is not good. So what we did is after 4th day, those patients who were remaining symptomatically respiratory point of view, we started sending them second report, and then we found that second report is turning out to be a positive. So this is something which we learned. So any respiratory problem, those who are clinically and HRCT wise or saturation wise, those who require higher oxygen or BiPAP or further respiratory management, we started keeping them in a gray zone only in spite of negative report. That's what we learn as far as patient management is concerned. And yes, as far as management goes, apart from oxygen, we try to delay intubation as much as possible. We keep them on a BiPAP or a high flow nasal humidified nasal cannula, which is, and then we ask them themselves to sleep prone lateral, which is helping a lot. And we involve them right from the beginning. We involve them in a respiratory exercise and all these things. And apart from that, yes, we are giving not dexamethasone, but then right from the beginning in last 2 months, we are using methylprednisolone to start with in a dose of 125 milligram QID. Then after 5 days, reducing to TDS, and then tapering like that. And we are getting excellent result. Only in those who are not responding cases, even we are giving a tocilizumab, but that is depending on his CRP levels and interleukin levels. But then in last 2 months, we must have treated almost 200 patients. Out of them, we had a mortality of 4 patients who were above 70 years with a lot of comorbid disease. But rest of the patients we could pull out. Maximum patients we could pull out on BiPAP and high flow nasal cannula. So that's what we had learned in last 2 months. Thank you.
Thank you, Dr. Hitendra. Very, very interesting, and very interesting to also recognize that the administrative response actually needs to very much involve the frontline providers and kind of a real understanding of how the logistics and the patient flow works. You've also set us up very nicely for our next question around pulse oximetry and how you're using pulse oximetry to help triage patients. And so I'm going to turn to Dr. Susan, and I'm going to ask you to tell us a little bit about ALIMA was instrumental in developing this COVID-19 decision support tool. I'd like you to explain a little bit about this tool to us, the rationale behind the tool, and walk us through some of the key points, if you would, Dr. Susan.
Thank you, Dr. Tom. So first, I need to point out that that Lifebox and ALIMA certainly worked on this together with input from other people. So I'm just the spokesperson here. The goal of this was to help frontline providers, and thinking of people who are working in health centers, for example, become familiar with pulse oximetry and become comfortable using it to identify patients who could potentially have COVID. So that was the first goal, is to develop this as a triage tool. And so that's why you see that we developed a list of clinical symptoms that should prompt the measuring of the saturation. And as this should be a living tool, I would also point out that given the high prevalence of silent hypoxemia, we should also probably included things like lightheadedness or headache, something that these minor symptoms that could actually be the sign of hypoxemia in an otherwise well-appearing person. So that's something we should probably change. The threshold that you will see here, I think, may be somewhat controversial to some. The use of a threshold of less than 94% saturation as categorizing somebody as at risk is not exactly what the WHO recommends in its latest version of its COVID treatment guidelines, where it classifies hypoxemia as less than 90%. However, most of the publications to date, primarily out of China, certainly used saturation of less than 94% as a definition of severe disease. So we're in this gray zone between 90 and 93% as to whether you are actually considered clinically hypoxemic or not. I would submit that this is probably a fairly complex question and beyond the scope of the discussion here today, and it probably has to do with what the likely etiology is of hypoxemia. Bronchiolitis and viral pneumonia are not the same thing, for example. Anyhow, so the first point is to make a triage tool that would allow frontline health workers quickly screen people. And then the second purpose of the tool, which is on the next slide, is to help guide clinicians in the use of oxygen once a patient is identified as hypoxemic. And so here we just provide simple guidelines as to how much oxygen to start a patient on, and according to their age, and how to, most importantly, use the pulse oximeter to guide oxygen therapy to keep an oxygen saturation within a reasonable limit, so that you can, for example, also not only use the tool to launch oxygen therapy, but you can also use it to titrate and to wean oxygen therapy and help patients come off when they're recovering. Also, we put in a special category for pregnant women because, of course, their saturation should be maintained slightly higher than people who are not pregnant. And then to also give, allow clinicians to use the oximeter as a sign of deterioration, and so that they can move the patient to a higher level of care if they are unable to maintain saturations with nasal cannula or mask or high flow nasal oxygen, and get them to a higher level of care. So that's basically it, as a triage tool and then as a tool that guides oxygen therapy.
Thank you very much, Dr. Susan. Just a little bit, kind of a separate question follow-up. Are there opportunities to start changing this tool, or in some way updating it based on the latest evidence? Obviously, we worked on this very closely when there was a lot of well, there's still a lot of things to understand about COVID, but this was the best we could do at the time. Are there ways you think that this might be improved, or is this still a good approach as a triage tool? I'd be interested in your thoughts.
Yeah, I think that of course it should be updated. Yes, it should be a living document. And as I said, I would probably modify some of the clinical symptoms in the first box, so that we would prompt people to be a little bit more generous with, or use oxygen or use pulse oximetry a little bit more broadly. For example, on people who have headaches or just general malaise, not feeling well, because you might detect some silent hypoxemia. And then second of all, in the oxygen and guiding oxygen therapy, I certainly think that we should introduce a recommendation for proning or changing of position to improve oxygenation, because that certainly is a simple measure that can be instituted and that might avoid somebody being transferred to a higher level of care for ventilatory support. I think that it remains to be debated whether we want to start putting drug recommendations on this tool or not. I think we might want to keep the drugs for a more comprehensive guideline. This is meant to be like a poster that somebody could put on the wall in a clinic or at a triage point to constantly remind people of how they should guide their decision making. And then, I don't know what, I think the question about thresholds is, it's a pretty complex discussion at the end of the day.
Yeah, no, I think that it's important. Obviously, we're hearing from clinicians around the world that they are already taking advantage of techniques like proning, which we'll get to in just a bit, and also some of the experience, like Dr. Hitendra had mentioned, about kind of accidentally discovering patients with COVID on just through over the course of routine care. So very, very interesting discussion. Thank you, Dr. Susan. I'm going to turn to Dr. Baweye, and I'm going to just ask you, Dr. Baweye, that pulse oximetry and oxygen therapy are bedrocks for helping manage and treat and diagnose COVID patients. Can I ask you to walk us through the basic guidelines that are being used for triaging patients in ALIMA's work in the DRC?
Yeah, thank you, Tom, again on comments. Just I want to share with you the presentation in front of you. If you look at the curves, we see that in the first week, we have, as the number of cases increase, we have also the need of oxygen also is increased, and with the mortality, which is also increased. So it means what I want to precise here, the oxygen and the pulse oximeter is the key in managing the COVID-19 case in the units for our experience. Besides addition with the anticoagulants or even dexamethasone, but the most important key is the oxygen and pulse oximeter to be taken each time frequently. So if we look at when we move to this curve, then we have the mortality that decreased, even though the number of admissions increased, but the oxygen needed is still high, and even it seems to be increased. Why? Because in the past 2 weeks, I tried by seeing this mortality and the number of the mortality which is high, and the number of admission with the need of oxygen. Last week, I decided to be beside the anesthesia doctors and the internal doctor, and also the senior doctors in the COVID-19 units to check and to understand what is the problem. So I spent all the weeks in the units, and we discovered that there is some soft skill that is very, very important. But what I want to preside in our protocol, what we decide, we classified in the first step. The first of all, we put the oxygen and pulse oximeter that are key. The second, we move to the tools that we need to be used, which is the oxygen concentrator and the cylinder. The third step is maybe we can use the CPAP, and the last, the intubation. Because yes, in the teaching hospitals, they have the capacity for intubating patients, but we reserve the intubation as the last option, but never we put the intubation as the second or the third options in our case. So most of the patients that came to the admission in our unit, we found them, the majority come with the desaturations around 60 to 80% of the saturations. And with the introductions already of the pulse oximeter at the triage, we know already where exactly to move our patient, if it is in ICU, which is the criticals, or if it is severe case, and the moderate case, which unit we can place, as others are classified, maybe the red zone or yellow zone and the green zones. So for the oxygen saturation, which is above 85%, what we use the nasal cannula and also the oxygen concentrators, because we have two types of oxygen concentrators. Those who have the capacity of delivering 5 liters of oxygen, and those who have the capacity of delivering 10 liters of the oxygen a minute. So as we are dealing with the adults, we use the oxygen concentrator who has capacity of 10 liters delivered. And if we have the oxygen saturation less than 85%, we go directly using the high concentrated mask with the oxygen cylinders, because with the oxygen cylinder, we can go up to 15 liters a minute. And if combined, if we think that the oxygen saturations with the concentrator, if is not possible, still less than 90, we move directly maybe to CPAP, or even CPAP or Bosniak or the Ervo 2 that we have. But in my presentation, I want to focus more on those two steps, the oxygen concentrator and the nasal cannula, and also the oxygen cylinder and high concentrated phase mask. We can move to second slide. Yes, so here I want to precise, according to the experience that I faced during the last week until the beginning of this week, I found that the majority of the case is troubleshooting problem. Troubleshooting problems. Why? We know that the concept by using the oxygen concentration in sub-Saharan Africa are more being developed by international NGO. Because having the hospitals with the oxygen plant is very difficult. So the oxygen, the international NGO would develop more the concept of using the oxygen concentrator. So even in most of the hospitals in Africa, we can find maybe 1 or 2 oxygen concentrator, but other problem, the maintenance cause a big challenge, a big problem. So I noticed that, yes, the patient is on oxygen concentrator, but maybe there is missing between the bottle that we put the water to be humidified. So maybe there is leakage, there is opening between the tubes that is taking the oxygen from the concentrator to the patient and between also the bottle. So when we want to humidify it, we have also the oxygen which is going outside. So never the patient will benefit from the oxygen. The reason why we found in the last week, maybe most of our patients, even though we put the oxygen concentrator, we never get the saturation, the maximum saturation we need, or even we shift to the oxygen cylinder, but we're still facing the same problem. So I move around and check all the oxygen concentrator, and I found the majority of our problem is related to the troubleshooting problem, is just checking when the patient is on the oxygen concentrators, is to check if really the tubes is not blocked anywhere else, or if the patient is properly lying down but is not compressing the tube, or if there is leakage anywhere, or also the maintenance, because the oxygen concentrator also have the plan for the maintenance, because we have the filter on the back of this oxygen concentrator that need to be checked at the frequency, because they should have a planning, a maintenance program properly. Because if we want the oxygen concentrator is running 24 hours and daily, but no maintenance, no checking the circuit, no checking also the tubes that is getting the oxygen to the patient, is a big problem. And this is the majority of the case that I have found. And another thing associated is that how the treatment, how the organization also of the treatment in the units. Because our unit, we have 50 bed capacity, and among those 15 bed capacity, the first 5 beds are dedicated for the intensive care unit. So the role of the doctors, medical doctor and the nurse, is very important in monitoring those patients under the oxygen. So what we do, the ratio of the medical doctor and the nurse that we put for 5 beds in the ICU, we attribute 1 doctor and 2 nurses. But in the same time, also we have 1 doctor outside and also 1 nurse outside. Because why? When under the goggles or face shield and also with the full PPE, sometimes it's very difficult that from inside the medical doctor can see exactly what is happening. And our ICU has a transparent wall because we put the plexiglass that can allow from the outside, we can visualize the patient directly in the ICU and also to direct talking, communicating with the doctor and direct them to see what exactly is going or what is not working inside to direct them. So combined these 2 strategies, I have found that the reason why we see care declining and maximum the patient that I have seen, even yesterday, we have almost 10 patients under the oxygen, 5 in the ICU. Those 5 in the ICU, we have 4 under the oxygen. But personally, when I check them, all of them, no one will need the oxygen titration till to 10 liters of the minute. The one that we titrate the oxygen is up to 6 liters a minute, and we got the saturation above 96%, and other also we titrate the oxygen till to 8 liters with the oxygen concentration. The reason why I want to point out the necessity of the troubleshooting problem that can occur with the oxygen concentration and oxygen cylinder, those are the basis and fundamentals in the COVID-19 management case. Because if we don't think, the difficulty is that if the medical doctor under the full PPE, sometimes it's very difficult to bend down to check all those small details, and also the nurse under the full PPE, when they are tired already, it's very difficult to check on the details, the small detail, the soft skill, which is very important in the proper management of the COVID-19 case. Those are oxygen dependent. But all of these, the aim is that the oxygen is also the drugs, that it need to be monitored. The reason why the pulse oximeter play a major key to decide if this patient if he's saturated with the oxygen around 6 liters a minute and he has a saturation above 94, when we have to decrease, when exactly to determine the amount of the oxygen that we need to be delivered to this patient to avoid also the oxygen toxicity, and maybe the oxygen can create another problem. So those are during the week, my experience, that my observations that I found and I saw in the COVID-19 treatment unit that we have in the Kinshasa Teaching Hospital that I want to share with you. Thank you very much.
Thank you, Dr. Baweye. Goes back to that old adage of strict attention to detail, and the idea of using partners and your team to support the entire effort is really, really important. I'm going to turn now to Dr. Ashraf. Can you talk us through the guidelines around oximetry and its use for triaging COVID patients in your institution in Bangladesh?
Yes, thank you, Tom. I'll just walk you through a very simple triage system that we are following in the Zakiganj Health Complex. It's a sub-district hospital, 50-bed hospital. So the triage, actually, when a sick patient is arriving at the health facility, so the triage starts from the emergency or OPD department. So we have 3 different zones. So first, I'll go to the suspected cases. So when we find any suspected cases, which can be a COVID patient or a non-COVID patient, so we send them to a flu corner. So flu corner has a dedicated physician with an infection prevention and control system, and they're well, after taking safety precautions and measures, they actually examine the patient, and then they do the RT-PCR, they take the swab collection. So this is what happens in the flu corner. So there are patients who comes with a positive or confirmed report of RT-PCR. So we, when they come to the emergency, we actually send them to the isolation ward, and I'll walk you through that in the next slide. And then there are confirmed non-COVID cases, which we actually send to the non-COVID section of the hospital for the general management or admission if required. Yeah, Alana, can you go to the next slide, please? Yeah, okay. So whenever a sick patient is coming to the to our premises, so as we know, the COVID-like symptoms, like for example, fever more than 100.4 degree Fahrenheit with cough or dyspnea, or even now like there are patients coming with anosmia or abdominal pain, sore throat, myalgia. So what we do is like we separate them into 2 sections. Like first is the suspected cases, and then confirmed if they have the as I said earlier, if they have the RT-PCR report ready. So these 2 sections are being classified into broadly into 3. We categorize them into 3 groups. If you can see the right side of the group, so they are the mild cases, but they do not require any admission. So these are those patients who have a little bit of respiratory sign. Their normal examinations are normal. They're eating and they're drinking. They do not have any other risk factors. So we do not actually admit them, but we actually counseling them, because the treatment is as per symptomatic treatment we are providing, and they are being followed up through phone. So we offer them 2 things. One is either institutional isolation, or if they want to go to home, so we actually counsel them to stay like isolate in home, and their family members should be quarantined, and we actually have a phone follow-up for them. So if you see the middle part, that is the mild cases which need admission. So these are those cases which have influenza-like illness. Okay, clinically they are mild cases, but with comorbids. For example, they have diabetes or hypertension, or even the high-risk pregnancy group, or a known case of ischemic heart disease or stroke. So what we do is we counsel them, and we actually admit them in the isolation ward. And the treatment is, of course, as symptomatic and is as per the protocol. But in addition, we are actually using the low molecular weight heparin for them. So, and the most concerning group is the moderate, severe, or critical illness, which you can see on the left side of the image. So this is those which are coming with respiratory distress, and who are having tachypnea more than 25 breaths per minute, or even their oxygen saturation is less than 94 or less than 88 for COPD patients. Okay, and if the patients are actually unwell, so we actually send them directly to the isolation ward, and we start with other symptomatic treatments. We start the oxygen challenge. Okay, so for these patients, actually, as I also said earlier, that pulse oximetry is, of course, the bedrock. Uh, Oxygen, we actually monitor their oxygen saturation very frequently, because some of the patients which we have seen that they are very well, but their oxygen saturation is less than 90%. So, but they don't know. But by the time we know that, like, it's already too late. So that's what we are doing is we are actually monitoring these patients with pulse oximeter. And the oxygen challenge, actually, in our health complex, we are using 2 to 6 liters per minute. We start with a nasal cannula, which is the very common dose. And so if these patients do not respond to oxygen, so actually the Zakiganj is 60 kilometers away from the main city. So it's a bit far. So what we do is we those critical cases, or who are suffering from acute respiratory distress syndrome, we actually refer them to Sylhet Shamsuddin Ahmed Hospital. So it's a government hospital which is dedicated for COVID patients, which also has ICU and ventilator support. And for those cases which are responses to oxygen, we keep them and we observe them actually routinely. Yeah, Alana, next slide, please. So, so oxygen therapy at Zakiganj Health Complex. So for the mild symptomatic cases, as the our national guideline actually says that below 94% of oxygen saturation, we should actually administer oxygen. So we start actually with, like, when it is like below 95%, okay, we start giving them the oxygen through nasal cannula. That's 2 liters per minute we start, and it's increases to 6 liters maximum. And for the proning, this will be for the moderate symptomatic cases. The prone position is at least 4 to 6 hours per day, and for severe cases, we are actually using more than 12 hours per day. Yeah. So next slide, please. Yeah. So we are supplying the low flow oxygen delivery, that is nasal cannula, which has up to 50% of the FiO2, and we also have simple mask which can deliver up to 10 liters per minute oxygen, and up to 60% of the fraction of inspired oxygen. So others we have, but we actually don't use. In practically, we are using the first two in our hospital. And then if the patient actually doesn't improve, then we try for the high flow delivery, like a high flow nasal cannula up to 70 liters per minute. But if that also doesn't, the patient doesn't respond, so we actually transfer or refer them to a tertiary hospital. Yeah. So next slide, please. Yeah, so similarly for the hypoxemia, what our guideline, we are following our guideline, that is like when the saturation is less than 92%, or for the children who are having clinical signs, for example, central cyanosis or nasal flaring, grunting in every breath, even severe lower chest syndrome with 70 breaths per minute, or even head nodding. So we start the oxygen therapy, and similarly, we are actually giving them through nasal cannula. Yeah, I think next slide you can. So yeah, so for the children, we are using nasal cannula 1 to 6 liters per minute, and we rarely use actually simple face mask, because WHO also recommends the use of nasal cannula. And so this is the basic actually triage we are following. And the important thing is that actually the pulse oximeter, because the oxygen saturation should be monitored, because to actually to rule out if there is any hypoxemia. So back to you, Tom. Yeah.
Thank you, Dr. Ashraf.
Yeah.
Very, very, very important very important distinguishing between the levels of oxygen support and very, very useful in how you're using pulse oximetry as well. Dr. Hitendra, would you walk us through some of your treatment protocols and algorithms with respect to oxygen and the use of oximetry in your institution in India? And remember, you're on mute. If you could unmute yourself there.
Yeah. Thank you. Pulse oximetry is very important tool in the entire management of COVID patient, right from diagnosis, that is from triage area, till the complete treatment. It plays very important role. Just since this, I just like to mention that in last few years, so many workshops I had conducted, Lifebox workshop for safe OR, and where we had distributed so many pulse oximeters. Now I am finding that they are coming into so much of use nowadays at tertiary, periphery level also, where they are just that is helping them as one of the important tool to diagnose or segregate the suspected cases. Coming to my institute, yes, it is a well established tertiary center. So as I said in the beginning, we have a triage area at the ER itself. So any patient, irrespective of his symptoms, whatever, his entry in the hospital is through that triage area only. And he has to go through this three things. One is history. In country like India, where COVID is, even now it is considered as a social stigma and taboo. So people are always in a dilemma. They know that they are exposed to some COVID situation or COVID patients or COVID surrounding, but they are scared also. But at the same time, they don't want to reveal also. So, they are a little bit of confused, depressed and all these things. So when they come to our place, most of the time they not only try to hide the history, they try to hide the symptoms also, because I don't know, thanks to our media, or unfortunately because of media now and because of all this social media, most of the people, they had become more clever than doctor as far as COVID is concerned. So much of write-ups and so many, and that is confused, that is adding to our problem right from the triage area. So they hide their history. So now over a period we learn how to deviate the questions and extract the history from them. They will try to hide the symptoms also, because of the various stringent rules of the government regarding the test to be done, whose test to be done, and where they should be placed or where they should be confined to, all these things. Because of that, we are facing a lot of problems in treatment part. At one place the government is fine at its own place for preventing the prevention, but then people are hiding their history and they are creating more problems. So in triage area, when patient comes, pulse oximeter is our basic tool to diagnose. If we found that patient is asymptomatic and if his saturation is more than 95%, we stamp them on their hand, we send their report as a suspect, and we all the patients get admitted in gray zone. We had entirely divided our hospital in 3 zones. There is no mixing of 3 zones. The patient goes to gray zone and his swab goes. If swab comes positive and if patient is still asymptomatic with a good saturation, we just stamp them on their hand and we advise them home isolation, strict home isolation, and just we send them, we don't admit them. And we inform the government authority also that this is the name of the patient, he is from that area, he is positive, but he is asymptomatic and we cannot waste a hospital bed for him. He is advised a home quarantine. And that is also as per our Supreme Court. Now, if the patient is asymptomatic, but if saturation is less than 95%, in that case, we observe them. If they turn out to be a positive, what we had learned over a period is slowly they start becoming symptomatic. They become, what we observe for is, apart from continuous monitoring of pulse oximeter, we watch their respiratory rate. It is very important. Slowly you will find they are becoming tachypneic. Their respiratory rate, we keep a chart of a respiratory rate. It also keeps on increasing. And then obviously, being a tertiary hospital, we send them through a HRCT screening, as I said, and first basic X-ray that helps us in further monitoring of these patients. So those patients, those who are turn out to be positive and not that much symptomatic, those who can be managed with nasal cannula or at the most venturi mask or a mask where we can give with a reservoir, we put them in a not ICU, but where we can just keep a watch to them and we admit them in that area. At the same time, we start them on a HCQ where we are using it in India, and then we send them their basic reports and observe them by giving oxygen. If they deteriorate, or if we receive a patient who's having a comorbid disease or any other things where he requires little further management, or whose respiratory rate is more than 30, 35 U, we send them, we admit them in an intensive care unit. And step by step, we always start with, as I said, nasal cannula, then high with a oxygen, reservoir oxygen. But most of the time, what we found out is their respiratory rate increase. And if we still ask them to go like that only, slowly, we find that they go in a fatigue. Because of oxygen continuous, they get ignored from their diet point of view also. And once the diet reduces, these people, they go into a problematic thing. So what we do is, those who become more those who require, those who cannot maintain their oxygen saturation on only oxygen or reservoir mask, we put them either on a BiPAP or we put them on a high flow nasal cannula with a humidification. With that, some patients, we find that they cannot even remove it for a few minutes for drinking or something like that, or having their meal. So for that, those cases, we go ahead with the RT and central line, those who require fluid management and all these things. So we can maintain their diet uninterruptedly through the RT feeds. That's what we do. From the drug points of view, as I earlier mentioned, we put them on ICQ, we start steroid to all these patients, we keep their watch on a CRP level, and those who are more symptomatic, we even send interleukin 6 levels. We give them low molecular weight heparin alongside, and if at all it becomes difficult for us to manage, because on the BiPAP or on a HF-NC, we advise them to self-prone themselves, and they very well cooperate. They themselves see the advantage, benefit of it. They themselves go into a prone positioning or all. Only those who become drowsy or those who retain CO2, because we keep on monitoring their ABG also at least once in a day. So those who go into a hypercarbic state or those who develop a metabolic acidosis, we intubate them and we take a control of a respiration in that situation. And then the management totally changes. Those patients, if we get a good, very high interleukin 6 level, even we go for a 1 or 2 dose of tocilizumab in that case. And we had found that most of the cases, they had responded very well. As I said, in last 2 months, we had almost 250 to 300 admissions, out of which only 4 patients we lost who were very elderly age with lot of comorbid disease, where sugar management was a problem because of steroid and all these things. Otherwise, we got excellent result. We could extubate them after 3rd or 4th day, put them on a BiPAP and slowly win them from BiPAP. But then, as I said, respiratory physiotherapy and all these things played very important role in these patients. Thank you very much.
Thank you, Dr. Hitendra. We have a couple more minutes before the end of this session. I'd like to ask you, Dr. Hitendra, a little bit more about some of your the way that you use proning. Would you tell us about the types of patients? What is the trigger for starting to think about proning patients? When do you institute proning protocols? And what is the protocol in your institution? You obviously have a very you have a tertiary center, so you have a lot of invasive options, but you obviously want to avoid intubation if at all possible. When do you start instituting proning protocols?
Sir, as far as proning is concerned, even those patients who are on a nasal cannula or nasal mask, we advise them to sleep as long as possible, we just tell them that whenever possible, you go into a prone position, and they very well adapt to that. They themselves see the difference, and they either go into a semi-prone or they completely make themselves comfortable in a prone position on their bed. And awake patient, it becomes very easy because they themselves make them prone, and they adjust their own comfortable position. Most of the time, even they just pull a pillow under their chest. So we had kept the proning policy absolutely free up to the patient. We just encourage them, we just inform them the benefit of it, and they themselves realize the importance, they experience. Because what we go is, what we had found out is, rather than treating the numbers on the monitor, yes, sometimes it shows 84, 80, 78, but patient is not that much, the feel of the patient becomes very important for us. Even if it is like a spirometry, we ask them to do a spirometry, but then we tell them they go for their feel rather than going for a numbers on the monitor. When they feel tachypneic or when they feel short of breath, yes, they stop at that point. Proning, yes, we encourage a lot of proning. Let me tell you frankly that we are advising all the patients to keep themselves in a prone position as long as they are comfortable, and that is helping a lot. Let them be on an oxygen cannula, or let them be on a mask, or let them be even on a BiPAP. If they are on a BiPAP or high flow nasal cannula, still we advise them to themselves take the position of prone, and once intubated, then it becomes little difficult to make them prone in that case. And that facility, we have only one facility where unconscious patient can be prone, and we need a hanger and all these things. So in those patients, we give just a trial of half an hour or 45 minutes at the most, and that too only twice, depending on staff availability and all these things. But those who are not intubated, we just keep on asking them. Apart from chest PT, we give more this thing on a chest PT, physiotherapy, and asking themselves to sleep in a prone. And we found that they tolerate it very well. They themselves become addicted to that. Whenever they find it, they just try to sleep in a prone position, and it is helping a lot.
Thank you, Dr. Hitendra. I'm going to take just a few more minutes. Actually, I asked Dr. Ashraf and also Dr. Baweye. First, Dr. Ashraf, has that been your experience with proning? You obviously have a center where you need to refer patients who need invasive ventilation. So tell us a little bit about how you are using proning to avoid, sending patients to higher levels of care.
Yeah, thank you. So what we are doing in our center is like for the moderate ill patients, like for example, their oxygen saturation is less than 95 but more than 93. So these kind of patients, actually we're doing the proning, and this is awake proning, what we call. Okay, so and it gives a very good result because proning actually increases the oxygenation, and we keep around 4 to 6 hours, or if as much as patient feels better. But for the severe cases, it's of course more than 12 hours proning should be done. And but we didn't do proning in this for the severe cases, because we are referring them to a tertiary hospital. And as like Dr. Hitendra said, yeah, I also agree that it gets difficult to actually prone a patient after intubation. So we can actually prone the patient, and then we can intubate, or if it's required, because it actually will reduce the injury to the respiratory system. Yeah.
Thank you. And Dr. Baweye, you had mentioned proning a little bit, but how are you using proning currently, given your situation?
Yeah, okay. In our situation, as I described before, how we organize our units, that in the ICU we have 5 beds. And those are where exactly we keep the more critical patients, and those also, of course, they need sometimes the hemodialysis, because to mention that most of the patients we receive, they have the comorbidity associated, especially the hypertension or maybe diabetes, and some also knowing already on the hemodialysis. And we have few among of them who for the first time when they have been admitted for the COVID-19 and they need hemodialysis. So majority of them, they go to sometimes the uremic encephalopathy, or they have an altered level of the conscience. So mostly we base on the human resource. So the setup of the human resource in ICU is completely different from the other unit, as we can say for the severe and the moderate case in the other units. So how we use in the ICU, we base mostly on the nurse that help the patients, especially on the prone positions, and also checking because we don't have enough the monitors. We have only for now 2 monitors in our ICU for the confirmed case. So as we see, but we have all on the bed, we have the possibility we have 5 oxygen concentrators for each bed, but we have only for 2 beds, 2 monitors. So from there, we can have the heart rates, all the parameters on the monitors. But for the patient who are not on the monitor, definitely we need frequently nurse to go inside and come outside and also to change it. The reason why I say our ICU has a transparent wall with the plexiglass that we can communicate, we can talk from outside, and the team inside also can hear us, and the response we can guide them also. And we have the doctor and nurse outside, and also doctor and nurse inside. So when they start already caring nursing, when they provide to them, all of them with the proning position and checking if there is any obstruction or even charting all the oxygen saturation. But we have the pulse oximeter for individual patient that we have inside. So this one, we connect them and to give us the oxygen saturations in the minutes. But we need also to report why the doctor who are outside, they cannot see directly the pulse oximeters puttings on the hands or maybe feet of the patient inside. But the reason why we have also to write, to report in the paper and put it at the glass, so for those who are outside, they can see how the oxygen saturation has been monitored for each patient. So mostly for the ICU patients, we base on the nurse who help the patient in the prone position, changing the position, and also changing for all the maintenance, checking also the tube if the oxygen is well circulating or no, and to titrate according to the saturations. So I can say we use more of the resource in the ICU to help the patient for the prone. But those who are on the other, we explain to them why the importance on the proning position, and also sometimes the patient also has to take the position that they feel more comfortable in taking into the account that they can also have access, they can breathe easily with the mask or if the nasal cannula that we put them on.
Thank you, Dr. Baweye. Well, we are a little bit over time, so I'm going to just wrap up and summarize. First of all, I want to thank all of our panelists, Dr. Susan, Dr. Baweye, Dr. Ashraf, Dr. Hitendra, for joining us. We've reviewed the use of pulse oximetry, some of the ways of escalating oxygen therapy. We heard from Dr. Baweye some of the strategies he's using around oxygen concentration, the importance of having teams work together to ensure that there's a good visualization of the entire unit. We heard from Dr. Ashraf a very concrete plan with respect to how his facility is triaging patients and starting to manage patients and then refer patients who need higher levels of care. And then Dr. Hitendra about some of the ways a high-level referral facility is managing patients, and then also how they're even managing some of the fears of patients individually when they're presenting. There's obviously a lot of patient fear, and we could probably spend an entire session talking about how do we manage some of the societal effects of the pandemic, information, misinformation, lack of information. So this has been a very, very interesting and very useful conversation. Thank you all for joining us today, for your questions, to our panelists. Thank you to our host, Assist International, and to our co-sponsors, ALIMA, Stanford University, and Lifebox. We really want to express our thanks and gratitude and support, especially to those healthcare providers around the world as you all work on the front lines to tackle this pandemic. We stand alongside you. We will this video session has been recorded, which we will be posting online and sharing shortly. And let me summarize there and turn it back to Assist International for any final comments and words of thoughts.
Thank you so much, Dr. Weiser, and again to all of the panelists. I mean, you've outlined everything well, so all I'll say is I just want to thank our funders and supporters that allow us to do these sessions: GE Foundation, ELMA Philanthropies, UBS Optimus Foundation, and Grand Challenges Canada. As Dr. Weiser said, we will be posting this, sending around a follow-up email that includes the presentation materials and the recordings in all 3 languages. And we do have a WhatsApp group that Elena, if you could just share, thank you. The QR code is here. If you have any issues, please let us know at echo@assistinternational.org in joining, but we do have this chat so we can continue the conversation. So thank you very much again to the team here and for everyone joining us today.